I'm about to show you how RPM companies are leaving millions of dollars on the table by ignoring the patients who need it most. 40 to 50% of your addressable market is walking away before they ever even open your box. And if you sell to health systems, this directly impacts your win rate. In this video, I'm breaking down how colorblind patient education is costing RPM vendors enterprise contracts and what to do about it. We're covering 4 mistakes RPM companies make, the revenue impact, and 5 fixes that your company can implement in just 10 weeks. Let's go. First, let's talk numbers. Black Americans' risk for hypertension is 60% compared to the general population. 77% are more likely to get diabetes, and 30% are more likely to die from heart disease. These are the exact conditions that RPM platforms monitor: blood pressure, glucose levels, heart rate, weight. So if you're building an RPM platform and you're not designing any patient education for Black patients, then you're ignoring 40 to 50% of your total addressable market. This is not about DEI or diversity initiatives. It's just bad business. And yet, when I audit RPM patient education, like onboarding emails, app instructions, and customer support scripts, I usually find 4 massive mistakes. Here are the 4 mistakes that RPM vendors make. Number 1, the reading level. The average RPM patient education is written at an 11th to 12th grade reading level, but the average American, and I'm not just talking about Black people here, the average American reads at a 6th to 8th grade reading level. That's a 3 to 4 grade gap between what you're writing and what your patients can understand. Here's an example. Ensure optimal adherence to your prescribed monitoring protocol by documenting systolic and diastolic readings biweekly. What? Check your blood pressure twice a day. Write down both numbers, the top number and the bottom number. Those 2 versions have the same information with completely different accessibility and reading levels. Most of your patients won't understand the first version, but everyone can follow the second one without rereading it or asking ChatGPT to translate. If your patients or consumers cannot understand the instructions you're giving, they won't ever activate their device or log in. They'll ghost your platform, and your health system buyer won't see any engagement data. Mistake number 2 is ignoring caregivers. 51% of Black adults are family caregivers, compared to 16% of white adults. These caregivers spend more than 30 hours a week managing medications, coordinating appointments, and navigating healthcare technology for their loved ones. But most RPM onboarding says things like, download the app and set up your device, like that patient is just by themselves doing it. In reality, it's more than likely their spouse, a sibling, or their child, whether it's a child or an adult child, setting up that device. The typical RPM email will say something like, your doctor has enrolled you in remote monitoring. Download the app to get started. And that's pretty much it. That's all they tell you. There's no acknowledgement that someone else might be helping them. There's no option to add a family member, and there's no duplicate instructions that are sent to their caregiver. So you've just excluded one of your end users, maybe even the real end user in that particular case, the person who's going to be troubleshooting at 2 a.m. when the readings won't sync. Mistake number 3, the trust deficit. 35% of Black Americans have very little trust in the health system, and there's historically great reasons why we don't. From 1932 to 1972, the U.S. Public Health Service studied untreated syphilis in Black men, withholding treatment even after penicillin became standard care. It was called the Tuskegee study. That's 40 years that they withheld care. Henrietta Lacks cells have built a multi-billion-dollar biotech industry. But you know what? Not only was she never told, but her family wasn't told, and to this day, none of them have ever been compensated for it. And today, Black women are 3 to 4 times more likely to die from pregnancy-related causes, even when you control for income and education. These few stats and facts I'm sharing with you are not from ancient history. They've all happened less than 100 years ago. This is the lived experience that shaped how Black patients interact with your technology. So your onboarding needs to explicitly address these factors. Who has access to my data? How will it be used? Can I opt out? Will my doctor actually listen to what I report to them? Your data is HIPAA protected. Only your doctor sees your readings. You decide what gets shared. You can stop at any time. Most RPM onboarding doesn't state any of that, and you may have unknowingly triggered historical trauma. Meanwhile, your device stays in the box. Mistake number 4, lack of visual representation. When I look at RPM websites and marketing materials, more than 90% of the stock photos that they use are of white people. Smiling white grandmothers checking their blood pressure, white couples walking on the beach. And the psychological impact of that to non-white patients is, this isn't for people like me. When that happens, you've lost the patient before they even have a chance to open the box. Representation matters, not as a nice to have, but as an actual conversion factor. So those are the 4 mistakes I see. And now let's talk about what this is costing RPM vendors. The revenue impact of this has 3 stages. Stage 1 is the sales cycle. Health system RFPs are increasingly requiring health equity metrics in vendor responses. So if you can't demonstrate cultural competency in your patient education, you'll lose before you ever get to the demo. Lost deal value per enterprise contract is about $500,000 to $2 million. Stage 2 is onboarding. Research shows that 40% of Black patients never activate their RPM devices when onboarding isn't culturally tailored. Your customer acquisition cost for each patient is $400 to $800. If you multiply that by 1,000 patients enrolled, then you've just wasted $400,000 to $800,000 on patients who never logged in. Stage 3 is engagement and renewal. Low patient adherence means poor outcomes data. Poor outcomes data means the health system doesn't see any ROI. If there's no ROI, that means the contract doesn't renew, and then you're back to square one. The total annual cost per health system is $1.9 million to $3.6 million in lost or wasted revenue. That's crazy. Meanwhile, your competitors who've invested in culturally tailored patient education are winning those same RFPs, achieving 75% device activation rates, demonstrating better patient outcomes, and renewing contracts at 2 to 3 times higher rates. That's the cost of ignoring Black patients. So what do you do about it? Well, I can give you 5 fixes that'll actually work and turn this all around. All right, here are your 5 fixes. Fix number 1, audit your reading level. Run all your patient-facing content through a readability checker like Hemingway app or Readable. Target a 6th to 8th grade reading level and rewrite every piece of clinical jargon. So you would replace something like optimal adherence with follow the plan and replace bi-weekly with twice a week. Use the same words that your patients would. Number 2, include caregivers in your design. Add a caregiver role to your account setup during onboarding. Send duplicate welcome emails to both the patient and their designated family member. Allow app access for caregivers with patient approval, and create a caregiver troubleshooting guide in addition to your patient guide. Number 3, use trust-building language. Add explicit data privacy sections to all your patient communications. Don't bury them in a privacy policy. Put them right in the welcome email. Spell out in plain language who sees the data, how it's used, and how to opt out. Use a conversational first-person tone. Say, your doctor sees your readings, instead of, data is transmitted to your healthcare provider. Number 4, visual representation. Replace your generic stock photos. Feature real Black patients and caregivers in your marketing materials, your app screenshots, and your video tutorials. If the budget allows, hire Black photographers to create original content. If your budget is tight, use authentic stock photo libraries that prioritize diversity. And I'll link a few of those in the description or put them on the screen. Fix number 5, cultural competency training. Train your customer support team on trauma-informed communication. Educate your sales team on how to position health equity as a competitive advantage in RFP responses. And develop 2 or 3 health equity case studies that show improved activation and engagement rates for your enterprise pitches. The total cost for all 5 fixes is between $5,000 to $15,000. The total time it takes, 10 weeks. And the ROI is clear. Your first enterprise contract win will pay for the entire initiative. I hope all this was helpful to you, but I'm not trying to put a guilt trip on you, okay? I get it. You're a health tech executive dealing with a million competing priorities. Adding a health equity audit to your quarterly roadmap feels like one more thing to do on an already overwhelming list. But the reality is, your competitors are already doing this work. Health systems are already asking for it in RFPs. And Black patients, the ones who represent 40 to 50% of your addressable market, are already disengaging because your onboarding language doesn't speak to them. So the question isn't, can we afford this? The real question is, can we afford not to do this? I created a free PDF guide called the $4.2 billion Opportunity, Black Patient Engagement in RPM. It includes all the stats, examples, and frameworks that I've mentioned here, fully cited with an implementation checklist. The link is in the description and pinned in the comments. If this video was helpful, Please hit the like button and drop a comment below answering this question. What's one patient education change that you're committing to make this quarter? I read every comment and I'd love to hear from you. Together we can make health equity profitable, not just because we want to make money, but because it's the right thing to do. Now watch one of these next.